we are going to talk about the pathophysiology of the thyroid gland. The initial video is talking about the normal physiology of the thyroid gland. So this video is going to measure on the pathophysiology of the thyroid gland. So the first condition you're going to talk about is hyperthyroidism. And this one means increased production of thyroid hormones in the body. So in hyperthyroidism, the thyroid gland usually increases in size. And because it increases in size, you'll have increased number of cells producing thyroid hormones. So what are the causes of hypothyroidism? Number one, we have an autoimmune disease called Graves' disease. It can lead to hyperthyroidism, and you're going to see the mechanism of cause. Then we also have benign tumors called thyroid adenomas, and we also have overtreatment with thyroxine hormone. Also, we have a condition called transient neonatal thyrotoxicosis, which usually occurs in pregnant women. And so we want to start with the Graves' disease. So it's the most common cause of hyperthyroidism, and you've said it's an autoimmune disease where your body produces antibodies against itself. So for this case, the antibodies being produced are usually called thyroid-stimulating immunoglobulins, TSIs. And these antibodies are produced against the TSH receptor in the thyroid gland. So once these antibodies have been produced, they'll go and attach to the TSH receptor, and they'll continuously activate this receptor. So when they continuously activate the TSH receptors, your thyroid gland is going to produce a lot of T3 and T4. So this will lead to high levels of thyroid hormones, which are T3 and T4 predominantly. So the high levels of thyroid hormones usually exert a negative feedback loop, and this is going to reduce the rate of TSH and TRH production. So when you run a lab test for you to make a diagnosis of hyperthyroidism, for Graves' disease, number one, you're going to have high levels of T3 and T4, but you're going to have low levels of TSH and TRH because of the negative feedback loop, both the short and the long negative feedback loops. Then again, you're going to run an antibody assay, and for the case of Graves' disease, we expect to have a very high levels of antibodies, the thyroid-stimulating immunoglobulins. So that's when the concluding statement we say that in Graves' disease, there's high level of T3, T4, but low levels of TSH and TRH. So this is basically a pathway trying to explain what happens in Graves' disease. So in the normal physiological apparatus, we have the hypothalamus producing TRH, which goes to the anterior pituitary gland to stimulate it to produce TSH. Now, once TSH has been produced, it usually goes and acts via the TSH receptors in the adrenal gland to make it produce T3 and T4. Now, in the case of Graves' disease, however, we see that we have our thyroid-stimulating immunoglobulins, which now come and bind to the TSH receptors in the thyroid gland, and this can even make the thyroid gland to be big, to enlarge, and produce more T3 and T4. So we see that in the Graves' disease, because of high levels of T3 and T4, we're going to have a negative feedback loop. Here we have a short negative feedback loop to the anterior pituitary gland, telling it to release less of TSH. And again, we'll have the negative feedback loop all the way to the hypothalamus, which will make it release low levels of TRH. So when you carry out an assay, we're going to find we have high levels of T3 and T4, but low levels of TRH and TSH. But again, you're going to form high levels of antibodies. So the next cause of hyperthyroidism is thyroid adenoma. And this is basically a localized benign tumor of the thyroid gland. It's a tumor, a benign tumor. So this tumor usually secretes large amount of thyroid hormones, and that's why it can cause hyperthyroidism. So when you run an assay for thyroid adenomas, you're going to find high levels of TSH, and sorry, here is supposed to be low levels of TRH. It should be high levels of thyroid hormones inhibits TSH, and TRH. So we'll have both low levels of TSH and TRH, but you're going to have high levels of thyroid hormones. The thing is that because the tumor is producing a lot of thyroid hormones, you can have a negative feedback loop to both the anterior pituitary gland and the hypothalamus. And this is going to make them to produce less TSH and TRH. Now, this is basically a diagram trying to show you a thyroid adenoma. Though you can't see the adenoma here, but you can see that in case you have a tumor producing high levels of T4 and T3, you can have a short negative feedback loop to the anterior pituitary gland, making it produce less of TSH. But again, we can have a long negative feedback loop to the hypothalamus, making it release low amounts of TRH. So when you run an assay for thyroid adenomas, we expect to have high T4 and T3, but low TSH and TRH. So the next one is called transient neonatal thyrotoxicosis, and this usually occurs in pregnant women who have Graves' disease. So remember, in Graves' disease, we produce a lot of antibodies called TSIs. So what happens for this condition? The TSIs can cross the placenta of the mom to the child. Now, when they go to the baby or the fetus or the embryo, they're going to stimulate the thyroid gland to produce a lot of T3 and T4. And right now, we have agreed that they usually stimulate the thyroid gland by binding to the TSH receptor. So a quick recap, transient neonatal thyrotoxicosis occurs in pregnant women, and the TSIs, or the antibodies produced, usually crosses the placenta to the fetus, and they stimulate the thyroid gland by binding to the thyroid stimulating hormone receptor on the thyroid gland. Now, this disease is usually self-limiting in that after some time it's going to subside. Approximately after 4 to 6 months, they usually subside without any treatment being required. So they're self-limiting and they don't require treatment. They'll just end on their own. So this diagram is trying to show us a picture of the transient neonatal thyrotoxicosis. We can see that this pregnant mom has Graves' disease, and this Graves' disease basically is production of antibodies against the TSH receptors. But because this mom has a developing fetus, these antibodies can cross through the placenta to the fetus, and they can go all the way to the thyroid gland to stimulate it to produce a lot of T3 and T4. And that's why these children might have hyperthyroidism, simply because they get the antibodies from the mom via the placenta. Now, what are the symptoms of hyperthyroidism? Number one, they usually lead to a very high state of excitability. Number two, they increase intolerance to heat. And number three, we have increased sweating. So for you to know the symptoms of hyperthyroidism, you need to know the normal functions or the effects of a thyroid hormone in your body. So in case you have a thyroid hormone, we usually have a lot of effects that it has in your system. So for hyperthyroidism, those effects are going to be augmented. They're going to be worse. And that is why you can see we have increased sweating. But we know that a thyroid hormone can cause sweating, but hyperthyroidism will increase sweating. We also have mild to extreme weight loss because thyroid hormones leads to metabolism and breakdown of fatty acids, carbohydrates, and even muscle. So that's why we are going to have mild to extreme weight loss. Then you're going to have diarrhea, muscle weakness, tremor of the hands, and exophthalmos. Usually some books will talk about a thyroid stare. So this is a diagram trying to demonstrate exophthalmos as seen in hyperthyroidism. You can look at this woman, you can look at the eyes, the way they are staring. So this is called exophthalmos, otherwise called the thyroid stare. It's usually common in around a third of the population suffering from hyperthyroidism. So the diagnostic tests for hyperthyroidism, number one, you're going to look at the BMR, and we expect to have a very high BMR. Then you're going to check the levels of TSH, TRH, T3, and T4. And we said that for hyperthyroidism, T4 and T3 are usually quite high, but TSH and TRH are very low because of the negative feedback loop caused by high levels of T3 and T4. But again, you can run an antibody assay, of which for Graves' disease, we expect to have a very high concentration of TSI. So for treatment, we have surgical removal of the tumor. In case you had a thyroid adenoma, you can just do a surgical removal or surgery. We can use radioactive iodine. You can use these compounds called propylthiouracil, methimazole, and carbimazole. They usually block peroxidase enzyme, which is very important for the process of formation of thyroid hormone. You remember, once you have taken in iodide ions, you need to convert it to iodine. We usually require a peroxidase enzyme. So if you give a patient these drugs, they're going to interfere with that peroxidase enzyme, hence you're not going to have efficient thyroid hormone production. Number four, we have thiocyanate ions, and these ones usually reduce iodide trapping. You remember we have the sodium iodide importer, which is very important to pump in iodide ion into the follicular epithelium. So thiocyanate ions usually compete with iodine for that symporter. So in a way, it's going to reduce the intake of iodine, hence reducing the production of thyroid hormones. Also, we have perchlorate ions and even nitrate, which can also have the same effect as thiocyanate. Now, in as much as you're using propylthiouracil and thiocyanate to treat hyperthyroidism, in case you use them in excess, or rather in case we have overuse of the two, we can have goiter. Why? Because in case of excessive use of propylthiouracil and thiocyanate, we usually have low levels of T3 and T4 because we interfere with the production of thyroid hormones. So because you have low levels of T3 and T4, we won't have any negative feedback loop. We won't have any negative feedback loop to the anterior pituitary gland. So the anterior pituitary gland will produce more TSH, and a high level of TSH is going to increase the growth of the glandular tissue. Hence, we'll have a very big thyroid gland, otherwise called goiter. So when you use these drugs in excess, you can actually develop goiter. So the next condition is hypothyroidism, and it's basically when you have low levels of thyroid hormones in the body. So what are the causes of hypothyroidism? Number one, we have autoimmune disease called Hashimoto's thyroiditis, where we produce antibodies that are going to destroy your thyroid gland. And number two, you can have congenital causes. We are going to see that, and you can also have iodine deficiency, especially in people living in endemic areas where we don't have enough iodine in soil. Then you can also have something called subacute thyroiditis. You can have irradiation, thyroid surgery. Sometimes you can do a thyroid surgery, hence removing or accessing some part of the thyroid gland. Now, this can be very detrimental because we can be producing low levels of T3 and T4. And again, you can have a disease of the pituitary gland because remember, for us to produce thyroid hormones T3 and T4, we need to have thyroid-stimulating hormone TSH acting on its receptor before we can have production of T3 and T4. So in case we have any disease of the pituitary gland reducing the production of TSH, then definitely we're going to have low levels of T3 and T4 being produced by the thyroid gland. So what are the clinical features? Now for this case, it will be the opposite from what we had in our hypothyroidism. So one, we expect to have weight gain. We'll also have goiter. We also have fatigue. We have constipation. The other one was diarrhea. Now this one is constipation. We'll have a dry skin because thyroid hormone is very important for sweating. We'll have cold intolerance. Remember, one of the stimulus for production of thyroid hormone is usually cold. Cold usually stimulates the hypothalamus to produce TRH, which can now lead to increased production of T3 and T4. So in case you have hypothyroidism, then it means that your body will be a bit intolerant to cold. Then you also have sinus bradycardia. Remember, thyroxine hormone and T3 are usually very important to increase the contractile force of the heart and even the heart rate. So in case you have low levels of thyroxine hormone, you're definitely going to have a very slow heart rate, otherwise called bradycardia. Then you're going to have hoarseness of voice as our next. Now we talk about Hashimoto's thyroiditis. Number one, I've said it's an autoimmune disease. That's why it is thyroiditis, TIS, meaning we have some sort of an inflammation. Now it's usually the most common cause of acquired hypothyroidism. So in this particular disease, we have antibodies being produced against the thyroid gland. So these antibodies will go and destroy the thyroid gland, hence reducing its capacity to produce T3 and T4. So usually it's familial. It can be inherited in a family, and it is most commonly found in females than in males. Now, antibodies that are usually produced in this disease can be directed to thyroglobulin, where, if you can remember, we have organification. Organification is simply where when we combine iodine and thyroglobulin, or the tyrosine in thyroglobulin, to form MIT and DIT. So in case you direct an antibody against that thyroglobulin, then we'll have inefficiency of organification. We won't form MIT and DIT. But again, these antibodies can be directed against TSH receptor. And remember, the moment you destroy TSH receptor, TSH hormone cannot bind into that TSH receptor because it's destroyed. So eventually, we won't have any stimulus for production of T3 and T4. So we'll have hypothyroidism. So what is the diagnosis? Number one, we have low levels of T3 and T4 for hypothyroidism, just from the name hypothyroidism. But we are going to have high levels of TSH. We're going to have high levels of TSH. So remember, we have the negative feedback loop usually from the T3, T4 to the anterior pituitary gland or the hypothalamus. But in case you have low levels of T3 and T4, we usually don't have that negative feedback loop. So because we don't have that negative feedback loop, we can now produce high levels of TSH. And that's why in patients with low levels of T3 and T4, especially for things like Hashimoto's disease, we expect to have high levels of TSH. But don't be deceived, because in case the problem was at the pituitary level, anterior pituitary gland, maybe it was not producing enough TSH, then definitely we're going to have low levels of TSH. So remember, we can have high levels of TSH because we don't have the negative feedback loop. But in case the problem is at the pituitary gland level, then you can have low levels of TSH production. Finally, you can run an antibody assay, and for Hashimoto's disease, we expect to find some antibodies. So treatment, number one, you can do replacement thyroid hormone therapy. Number two, if it is congenital, then you need to give thyroid hormone for life, because these patients will never produce any thyroid hormone. So in case it is congenital, you need to give thyroid hormone treatment for life. So what is congenital hypothyroidism? Now, from the word congenital, you're just born with it. And you have different conditions that can lead to congenital hypothyroidism. Number one being agenesis or dysgenesis of the thyroid gland. Agenesis means that the thyroid gland is not formed at all, while dysgenesis means that the thyroid gland is formed in a very haphazard way. We can also have this homogenesis, where we are producing hormones, but they are not in the right form. We are forming a very defective hormone. And we can also have ectopic glands, and we can also have maternal hypothyroidism. So these four are the major causes of congenital hypothyroidism. So remember, if you want to make a diagnosis of congenital hypothyroidism, never use the clinical examination. Why? Because a newborn who has congenital hypothyroidism is usually normal at birth. The reason why they are normal at birth is because they usually depend on the thyroid hormones from the mom. So in utero, the maternal thyroid hormones can cross the placenta to the newborn. So when they cross the placenta to the newborn, the child will seem to be normal because the child is depending on the maternal thyroid hormones at birth. But over some time, a week or so, you can now see the signs and symptoms of hypothyroidism in that child. So in case of congenital hypothyroidism, we usually use the biochemical test at birth rather than the clinical examination. Because for the clinical examination, the child, the newborn, will be normal. So we have this condition called cretinism, and it's basically extreme hypothyroidism during fetal life. So because of this extreme hypothyroidism, we usually have failure of body growth and mental retardation. So the child won't develop well, and of course, will have some mental issues, hence mental retardation. So this cretinism can either be due to a congenital disease, or rather it can be due to an endemic cause where someone is living in areas of insufficient iodine. So it is important to understand that this disease usually affects the skeletal more than the soft tissue. So because it affects the skeletal more than the soft tissue, these people are usually very short because the bone doesn't grow enough because it has been affected more. But they're going to be very stocky in nature and very fat, because even though this condition is also inhibiting the soft tissue, but it is doing so at a very slow rate compared to the skeletal growth. So because of these aspects, we usually have disproportionate rate of growth, where the tissue will look like they are very large, but the child will be very short. So we usually describe a cretin child as an obese, stocky, and a short child. They are short because the skeletal growth is highly inhibited, but they look obese and stocky in appearance because the soft tissue are not that inhibited as compared to the skeletal system. So occasionally, again, the tongue might be very, very large, because a tongue is basically a soft tissue, so it might be very, very large. And these people can suffer from obstruction, and thus they can have difficulties in swallowing and breathing. Sometimes they can actually be choked with their tongue. So this diagram here is basically trying to describe to you cretinism. You can see we have two children, one to the left and one to the right. So the one to the left looks to be normal, maybe just that is emaciated something. But looking at the child to the right, you can see that the child is, number one, very short, and the child looks obese. So we have that stocky appearance of the child. Now, this is because the skeletal system has been inhibited more than the soft tissue. Yeah, so this is an example of an endemic goiter, especially for people living in areas where we don't have enough iodine in soil or enough iodine